Come on. All right, ECG paper. I think Mary went through this back when she was going through EKGs. We know that there's a certain, for every millimeter of distance, there's a 0.04 seconds that has elapsed. And the height has to do with how many millivoltage you end up having. And the big boxes are 0.2 seconds. The small boxes are 0.04 seconds. It kind of gives you an idea, so you can plot out durations of things like PR intervals, things like QRS duration, things like the QT interval. So this is the way we're going to approach each of the ECG tracings. We're going to determine the rate first of all. We're going to determine if it's regular or irregular. We're going to take a look at the P wave. Is the P wave normal, or is the P waves all the same? Is there more than one P wave for every QRS complex? We're going to take a look at the duration of the PR interval, take a look at the QRS complex, and we'll find that there's not always all three of those wave there, and then we'll take a look at the ST segment. Multiple ways to determine the rate. I don't care how you get there as long as you get there. Okay. There's most strips that you see are 6-second strips. So all you need to do is count the number of QRS complexes and the number of R waves and multiply times 10. That's a simple way. A little more exacting is to count the number of large boxes between two subsequent QRS complexes and divide that number by 300, or divide that into 300, I should say. And even more exacting, more precise, count the number of small boxes between two adjacent QRS complexes and divide that number into 1500. Now, in theory, they should all be relatively close, but the last one's going to give you the most exact of all of them. So this is a 6-second strip. There's a little marking here, there's a marking here, and there's a marking here. So between these two, we can figure out how many complexes we have. 2, 3, 4, 5, 6, almost 7. So the rate would be probably high 60s. I could also count the number of big boxes. 1, 2, 3, 4, 5. Divide that 5 into 300 and I get 60. And I can count 5, 10, 15, 20, 25 into 1500 and we get about 60 also. So you can see you get a little more precise as you go along with them. Now that's assuming that it's a regular rhythm, which this is. Again, a 6-second strip. 1, 2, 3, 4, 5, 6, 7, almost 8. So high 70s. And again, you can do the other mechanisms in the same exact fashion. Cool? So I would feel comfortable giving you a tracing and say what's the rate. And there's just some more examples to practice with. This is just going through the different waves that are present. The first positive wave you encounter typically is the P wave. It's representing atrial depolarization. You then have the first negative deflection after the PR interval. Or after this isoelectric line after the P wave. The PR interval really is the combination of the P wave up to that Q wave. The first negative deflection is going to be called the Q wave. The first positive deflection is the R wave, and the the negative deflection after the R wave is an S wave. And we'll find there's all kind of combinations that can end up being there. Then there's a plateau, an isoelectric line, the ST segment, followed by the T wave. And the QT interval is that point from the beginning of the Q wave to the end of the T wave. And they all have significance in some fashion. So let's take a look at the P wave and the PR interval. That segment between the P wave and the beginning of the QRS is known as the PR segment. P waves can be normal in shape, or they can be altered in shape. And what you need to do is identify when that occurs. So for instance, the second one there is notched, meaning that in the direction the lead is looking, there's a point where the impulse is moving in that direction, it turns around and starts again. That's why we have a notched. Because there's a negative portion to that waveform, it's going in the opposite direction. Does that make sense? Whenever you see a wave that's negative, it's going away from the view that you're looking at. Sometimes they're peaked, sometimes they're very low in height, and in this case, they're actually inverted, which would imply what? In the lead I'm looking, yeah, exactly right. In the lead I'm looking, if I'm on lead 2, the direction of view is this. If the wave goes this way, it's a negative wave. So if it's emanating from the node, the atria is going to be innervated in a backwards fashion, going upwards from the bottom to the top. It's going to be a negative waveform.
So would you see that like continuously, or is it just
no?
Sporadic?
Well, yes. It can be for an isolated beat, something that we're going to call a premature junctional contraction. It can be in a continuous basis, a junctional rhythm. It can be sporadic. Anything's possible. PR interval, normal 0.12 to 2.0. Kids may have a little bit longer or a little bit shorter. But for the most part, we'll just go with 0.12 to 0.2. Obviously, as the heart rate increases, that value has to decrease, just simply because you don't have enough time. When you get longer than 0.2, we're starting to talk about some impaired transmission across the AV node. Okay, and shorter than 0.12, actually, we'll see that with that junctional rhythm, because it's so close to the AV node that the origin of that beat. QRS complex is really, again, a series of multiple waves that are there, positive and negative deflection, or it represents ventricular depolarization, and anything greater than 0.1 second we're going to consider to be a widened QRS complex. Under normal conditions, you probably won't see a Q wave. That's actually, in most cases, especially a large Q wave, it's indicative of damage. QRS complex greater than 0.1 is definitely abnormal, and it usually implies that we have a ventricular origin. We'll talk about that later. And the way that we determine that there is an old infarction present is by the presence of a prominent Q wave in leads which are indicative of that part of the heart. So somebody can have an MI 15 years later, that Q wave will always be there. We can say it's an old anareceptal MI. Multiple ways to define this. This is out of your text. Here I have a Q wave as the first negative deflection. R wave is the first positive deflection. I might just have an R wave. I might have an R wave and an S wave. I have an R wave, positive deflection, S wave, negative deflection. Another positive reflection? Yes, we call that R prime. This one I have an R, an S, another R, another S, RS, R prime, S prime. And the weird one is just when we just have a big negative deflection and no positive deflection at all is called a QS. Okay, so you should be able to pick up on the fact that you don't necessarily have to have all three. In fact, you rarely do. And especially in this situation, I have a very small R wave here. And we'll find that as we go from V1 through V6, we see that R wave shape change, growing. And that has some kind of significance. Okay. Then we have the ST segment. That's the portion between the QRS and the T wave. The beginning of the QRS complex we're going to call the J point. And this is that repolarization period of the right and left ventricle. It's normally isoelectric. When it's something where the ST is lower than where the QRS ends, we're going to go ahead and say that that is depressed. If it's higher, it's going to be elevated. And they're indicative, as it says there, ST depression is indicative of ischemia. ST elevation is indicative of injury. And I need to go one small box after the J point to evaluate this. So here's my J point. It's the end of the QRS complex. Go one box over and evaluate, is this at an isoelectric line? Is it the same as between beats? Or in this case, you can see that it's elevated. Or in this case, you can see that it's depressed. So find the J point, go one box to the right, and where is an ST segment as it relates to the isoelectric line? Can everybody see that? It's pretty straightforward, but you may. So here's an ECG tracing where you can see there's some slight elevation here, but look how much larger it gets as you're going along. That's the evolution of the ST elevation MI, a STEMI. Find my J point, go one box to the right, and what do I have? Is it at the isoelectric line or is it elevated? You can see that it just gets progressively elevated as we go. Do you see any ST elevation in any of these tracings? How does lead 1 look? ST okay? Lead 2? Here's my J point. I have some elevation. 3? AVR we can always ignore because AVR is a goofy lead. AVL? It's depressed, isn't it? Okay. AVF? Elevated. Okay. Now, there is kind of a rule that depending upon where the heart is being involved, certain leads go together. And in this case, 2, 3, and AVF always will point to the inferior lead. If you think about it, lead 2 looks this way, lead 3 looks this way, lead AVF looks this way. It all looks towards the bottom. We'll find that this change we're seeing in AVL and the change in the depression we're seeing in V2 are what we're going to call reciprocal changes. And they kind of do the opposite of what the other ones are looking at. So that would be an inferior wall MI evolving. Finally, the T wave is ventricular repolarization. We know that there's a refractory period in there, both absolute and relative. It's normally oriented in the same direction as the QRS complex. And its height gets a little bit larger in the precordial leads as compared to the limb leads. When we start seeing some myocardial damage done, the ischemic changes, it actually flips itself over. And it also will change in the presence of alterations in potassium level. So here's hypokalemia, very flat T wave. And in this case, there is something called a U wave. I will never ask you anything about the U wave. And then you can see a tall peaked T wave is indicative of hyperkalemia. So these are the values that you should know related to our initial assessment of tracing. And you need to do this for each of the 12 leads. Well, actually, 11 of them. We're going to skip AVR. Let's talk about artifact. This is basically something where we can't see what's really going on because there's something interfering with our view of it. Can be everything from a electrode that's just dried up, is not conducting well. Some male with too much chest hair. I don't think I've seen too many females with excessive chest hair leading to problems with this, but I'm sure it's possible. Loose connection, muscle movement, and 60 cycle. These are the three that I want you to know. This is 60 cycle interference, and it's basically where you can't make out what's going on between QRS complexes because there's something else interfering. This would be an example of somebody using an electric shaver while they're trying to clear off that chest hair. Second one is loose wires, where you don't have good contact. You see all kind of movement. I can't make out what the underlying rhythm is because I got artifact. And the last one is muscle tremors. Kind of looks like 60 cycle, but it's not as clean. 60 cycle, if you look, is very very reproducible, where this one is much more difficult to pick up on. Okay, this would be an example of somebody shivering. If you're ever in the CCU and you really want to have fun, go like this with your electrode and watch the nurse go crazy or tap it. Nasty. All right. I believe Mary talked about axis deviation when we were going through 12 leads, but we're going to use this to determine hypertrophy of one of the ventricles, one way or the other, the presence of a bundle branch, or the presence of damaged tissue. And basically just saying which way overall is the current flowing. The normal deviation, if I were to take and look at 4 quadrants, the normal deviation is in this direction. That's normal. We're to consider anything that's up there to be left, anything down here to be right, and this to be indeterminate. Okay? Vaguely remember this? Okay. I don't care. I'm not a big fan of saying, well, this is a 62 degree deviation. I don't care. Tell me which quadrant it's in. And what we need to look at is where is the net deflection that is present. So here I have a Q wave that's got 2 boxes down. I have an R wave that's 12 boxes up. I have one that's 2 down. So my net deflection is 8, a positive 8. Here I have a positive 8 and a negative 4. I have a positive 4. Everybody see where I'm getting those numbers from? Okay. So which way is the QRS complex deflected? Up or down? And what I need to look at is 2 leads. And these 2 leads are very specific. I need to look at the lead 1, and I need to look at the lead AVF. If you think about it, lead 1 goes from my right shoulder to my left shoulder, goes in this plane. AVF goes at a perpendicular point to that. Yes? If they're both positive, lead 1 is positive, overall, has a net positive number of boxes, and lead AVF is positive, that means they're going to be in this quadrant right here.
That's considered normal.
That's considered normal. Okay. If I have a negative deflection in lead 1, that means it's not up here, it's down here. Lead 1 goes negative. Lead 1 goes towards the left. But AVF is positive. It's pointing downwards. That's the direction it's supposed to go. That means I have a right axis deviation. Positive deflection in lead 1, I go from this point. That's my positive deflection in lead 1. But a negative deflection in AVF. That's a leftward. And then the final one where it's in that upper left quadrant, they call it northwest. I've never seen that terminology before, but that's what your book calls it. I've seen it called no man's land, extreme right. I've seen it called a couple different things. So again, right axis, left axis, or the weirdness. And this is just another picture showing, again, here's my ECG tracing so I can determine which is which.
So you don't even know the degrees, though, like 90?
Nope. Makes life a whole lot easier. But I would expect you to be able to identify an axis deviation and why. What causes it. These are all just the same thing being said over and over again. Normally, you're going to have that direction going towards that lower right quadrant. Because the left ventricle is thicker, that's kind of the direction that the current normally moves from the right atrium, from the sinus node to the AV node and on down. Important point here. It's always going to move toward hypertrophy and away from infarct. Toward hypertrophy, away from infarct. Well, I mean, that makes sense. Dead tissue, it can't move towards it. It's got to move away from it. So here I end up having positive deflection in lead 1, positive deflection in AVF. I have a normal axis deviation. Left axis, meaning I have a positive in 1, a negative, overall negative in AVF. And this could be just simply because the diaphragm is shifting the heart upward. Pregnancy, ascites. Could also be because of a left block. A block is going to pull it in its direction. Left ventricular hypertrophy, or an inferior wall MI. Remember, the inferior wall is fed by the right side, the right coronary artery. So that's often that right side is what it's picked up on. Right axis deviation, where I have an overall positive in AVF but a negative in lead 1. This is going to be right ventricular hypertrophy. Or a lateral MI. So again, what's in the direction of lead 1 will be the lateral wall. This is looking the other way. We also see it in COPD and dextrocardia, but those are kind of odd ones. And in no man's land, really where we see this occurring is cardiac pacing, or somebody who has a heart transplant. We also see it with VTAC, because that's where it's emanating from the lower portion of the heart and moving upwards. So what's my deviation? Do I have any axis deviation here? What leads do we look at?
1 in AVF.
1 and F.
That would be to the right. Right? No, left.
Lead 1 is going
Up.
this way.
Yeah, so left.
AVF is going this way.
So left.
So it's a left axis deviation. It's right axis deviation. Then the question would be, what would cause that? A lateral wall MI, right ventricular hypertrophy. Making sense? It's a whole lot easier, I think, than the way that you guys did it with Mary. Huh?
She said we're going to teach us that.
Oh, okay. To me, it's just, all I need to know is right or left or normal, or undetermined. How about this one? Left. That'd make a great test question. Okay? All right. So when we're looking for the ischemic or looking at the evolution of a myocardial infarction, we're going to look for the T wave, we're going to look for the ST segment, and we're going to look for the development of a Q wave. These are the processes by which that ends up changing. And this would be a very good, I think I blew this up for you in the back, and this is a really, really good one that you end up seeing. Right before the MI actually starts, when there's ischemia present, the T wave actually flips. And we don't normally see this because they're not presenting to us yet with this. Once the acute process starts evolving, and we start having this acute myocardial injury happening, so ischemia, injury, infarction, then we end up seeing the T wave flip itself back over again, and the ST elevation happening in the leads where it's pointing towards the damage. The other leads, there may not be any change at all, or reciprocal changes. Once it keeps on evolving, a few hours later, I start seeing the development of a significant Q wave, along with that ST elevation in a upright T. Then, after a couple of days, the Q wave will never go away, but the T wave flips back over, gets smaller, returns to normal. And the only thing you're left with is that significant Q wave. This is the evolution of an MI. Starts from just some ischemic areas. As the ischemia doesn't get resolved, it becomes an injury. With an injury, you can still recoup that tissue. It's not fully gone yet. It's not until the actual infarction happens that death occurs to the myocardial tissue. And at that point, you got a permanent Q. We're going to call this process of the onset of chest pain and the development of angina and damage acute coronary syndrome, and there's really three separate ones that are here. One is unstable angina, which is basically it doesn't resolve itself when the patient rests. So I'm shoveling snow, I get chest pain, I sit down, the chest pain goes away. Okay, that's resolved angina. I sit down and the chest pain does not go away. That's unstable angina. Second one is non-ST segment elevation. This is where you don't have a Q wave, but you still do have a myocardial infarction. There are rare cases, not rare, I shouldn't say rare, but there are cases where it's a non-STEMI, and we're not going to go down that path. We're going to focus primarily on this ST elevation MI, just because it gets a little bit deeper than we need to go. Okay. What causes this to happen is really to the extent to which that vessel is occluded. If it's a big obstruction that's already there, it's not going to take a whole lot more to put strain on it to close it off. Also depends on the amount of collateral circulation you have. A 40-year-old coming in with chest pain and ST elevation is a whole lot more scary than an 82-year-old. The 82-year-olds build up a lot of collateral circulation, a lot of other pathways that can get around that obstruction. When you're young, you don't have that availability. And it could be transient in nature too. There's actually a special type of angina called Prinzmental angina that is not due to blockage, but rather due to coronary artery spasm. Have you ever drawn a blood gas and the artery goes into spasm? Same idea here. Coronary artery just starts spasming. And it's just like a Charlie horse. It'll resolve itself and the angina goes away. Okay, let's talk about ischemia. Ischemia, again, is where demand exceeds supply. Usually it's due to an atherosclerotic plaque breaking off, but as I mentioned, it can also be a vasospasm. In the process, you can also be reducing delivery simply because I got a tachycardia that's so rapid that I don't have adequate filling time. And we could also just have a overall reduction in coronary perfusion pressure, just secondary to the patient being hypotensive. Ischemia will progress to injury and eventually infarction if it's not treated. So that's why it's so important to pick up on ST changes and T wave changes before the development of the Q wave. We need to reduce the oxygen needs by reducing workload and increasing coronary perfusion pressure. We do this through vasodilation with nitroglycerin. Here's the plaque. You can see the plaque just ruptures and you end up having that floating downstream. Here's that plaque. And you get a clot that forms at that point. That's the typical reason why you end up having an obstruction of the coronary artery. So with that ischemia, you end up having problems with repolarization, which is why the ST segment and T wave starts changing shapes. We'll initially have that inversion of the T wave, but again, that typically isn't picked up on because we're not watching this on an ECG tracing while it's happening. And we said it's associated with the leads where the damage is, and in the opposite leads, but face the opposite side of the heart, you'll end up having reciprocal changes. So here, for instance, you can see the zone of ischemia is this light yellow, zone of injury, zone of infarction. And you can see with the zone of infarction, you have the development of the Q wave. With ischemia, you have the inverted T wave, which isn't there that long before you start seeing the ST elevation. But once you get to that point, that's dead tissue. Okay. And again, if you look at the opposite side of the heart, something that's looking at this side, it's going to be reciprocal changes. It's going to be exactly the opposite. So I have an upright T with ischemia. I have an ST depression with injury. So, ST segment depression, T wave inversion. We're looking at some ischemic changes. It's in V5. As we'll find, that's the lateral wall. Ischemia lasts long enough, we change the injury. This is the critical period. This is the time where we need to get something to reperfuse that, that artery. Time is muscle. So we will use things like fibrinolytic agents, TPA. We'll use things like coronary angioplasty. See if I can write this. Percutaneous transluminal coronary angioplasty. It's a fancy name for doing a cath. And if worse is worse, we end up taking them for a coronary artery bypass graft. We use some other artery to branch into beyond the obstructive point. Often it's internal mammary glands, internal mammary artery. So what we start seeing is that ST segment elevating, secondary to the process of the depolarization not being entirely complete. And again, you'll see reciprocal ST depression. And then lastly, we'll end up seeing the tissue dead In that case, you end up having these mediators leaking into the membrane, into the bloodstream. So we'll see a spike in the troponin level, the creatinine kinase myocardial band being increased, and the level of myoglobin, which is altered from hemoglobin present. This is the WHO's diagnosis. This is the American College of Cardiology. They're kind of on a similar basis, but you need more than just an EKG change. You need to have some enzymes. You need to have pain that is historic, related to these alterations in ECGs. And again, a development of a Q wave is the endpoint. And I think we'll stop there.